growth, increased strength, endurance, bone mass and bone density, accrual and maintenance. And then the third, growth of hair throughout different parts of the body, and skin changes as well, very important for our pediatric and teenage population. The effects of a low testosterone are different at different stages of an individual's life. Low testosterone during a pubertal age causes a slower than expected vertical growth or yearly height velocity. There's a decrease in muscle mass and bone density or bone strength accrual, and there's a lack of secondary sexual characteristics such as pubic and facial hair and a deepening of the voice. In adults, the effects of low testosterone are less nuanced and more obvious. Fatigue, sleep disturbances, concentration issues, libido reduction, erectile dysfunction are just some of the things that are seen. There's increased body fat, decreased muscle mass, and development of certain diseases and disorders such as type 2 diabetes, metabolic syndrome, cholesterol issues, and cardiovascular disease. This I just wanted to include here. There are some cautions and myths that you'll find on the internet and various support groups. I just thought this illustration was humorous. The man on the left is the one with optimal testosterone. I don't necessarily agree with the top three indications here of a sharper mind, confident, and happy, but I certainly agree with the other ones regarding muscle mass, healthy heart, healthier libido, stronger bones, and plenty of energy. The man on the right, as I mentioned before, there's increased fat tissue, increased risk of lower libido, increased risk of decreased bone density, and osteoporosis. So there are some truths to this, but certainly some myths as well that you'll come across. Testosterone in our pubertal or teenage population affects different things. Classically targets the male target tissues we say in endocrinology. So lengthening or growth of the penis, increased intratesticular cellular proliferation and development, sexual hair and scrotal development, acne development, muscular development, and breakdown of lipids and cholesterol. So the typical amount that's released from an adult testicle is about 5 to 7 milligrams per day, usually seen in adult males and those boys toward the end of their pubertal progression. This amount is far less during the early and mid stages of puberty. In fact, the amount of testosterone that's released from the testicle in pre-pubertal and boys starting puberty is really what we call slow and sustained, which is very, very important to appropriate yearly height progression and height velocity during those pubertal years. And I just want to point out here how important it is, testosterone hormone, to bone density and bone mineral accrual. The testosterone itself classically is important for the formation of bone structure on the outer layer of the bone. And then estrogen, which all boys make at various points in their life, is important for the inner layer or inner surface of the bone. What I'll say here is testosterone helps lengthen the bones and stretch them out, making the individual taller, makes the bones stronger. And the way that the bones are lengthened is by these things called the growth plates towards the top and lower end of each bone throughout the body. And it's that growth plate that's constantly undergoing remodeling and regeneration that produces more bone and lengthens the bone and ultimately the individual's height. At some point during the later stages of puberty, testosterone is made in such a large amount that a small amount of it in the males is converted to estrogen, and estrogen is ultimately what closes those growth plates there, and the individual stops growing. So as I mentioned in the previous slide, going back, you really don't want a whole lot of testosterone up front when you're starting these males in puberty. You want a slow and sustained amounts in a normal male, or if you're supplementing with testosterone medication as the physician, you want to give it in a very pointed, slow, and sustained formulation to get them to the proper height and to avoid the early or premature closure of those growth plates from too much testosterone converted into estrogen in the individual's body. So without further ado, how do we get from point A to point B? How do we get from that child who should be going into puberty, but they're not naturally, and to a point of age 19, age 20, to make them look fully adults and get them with the best height acquisition that they can? Well, let's start with some definitions. Delayed puberty, how do we define it? In general, it's classified as a lack of testicular growth by age 14. Clinical definition is the absence or incomplete development of the testicles and the secondary sexual characteristics bounded by an age at which 95% of males of that particular ethnic background have initiated sexual maturation. The way we define it based on laboratory definition is a first morning testosterone level below the reference range for that age or that stage of puberty, and a first morning ultrasensitive luteinizing hormone and ultrasensitive follicle stimulating hormone level below the reference range for that age and that definition of puberty. How do we treat hypogonadotropic hypogonadism? Well, as all things in endocrinology, we try to replace the hormone that's missing. And we can do this very easily, as we've had decades of experience with intramuscular testosterone. This is the first line treatment. It started sometime between ages 13 and 15. Usually the males who have an existing diagnosis of hypogonadotropic hypogonadism will start testosterone intramuscularly by their provider close to age 13. Others who may not have a clear-cut diagnosis of hypogonadotropic hypogonadism, and it's something that's ongoing, underway, being investigated, may not get started on testosterone until age 15, once the diagnosis has kind of been revealed. Doses can be easily adjusted to match the requirements at different stages of pubertal development to avoid growth plate closure and bone demineralization. And I'll get more into this in just a moment. So long-acting testosterone comes in two different brands, testosterone cypionate and testosterone enanthate, both 200 milligrams per 1 milliliter in formulation. How do we replace it? Well, it's dependent on the age and stage of that individual's pubertal progression. If, let's say, for example, number one, they're not in puberty yet, prepubertal, we'll start them on 50 milligrams, which is 0.25 mLs intramuscularly every 28 days for 6 months. We'll then assess the response and up the dose to 100 milligrams or 0.5 mLs every 28 days for the next 4 to 6 months, increase by another 50 milligrams once a month for the next 4 to 6, another 50 milligrams for the next 4 to 6 months. And then the final adult dose I put here that all these individuals started on testosterone replacement will be on is 200 milligrams every 28 days, 200 milligrams IM every 2 weeks. Another example I put here, but this is just an example. There's many different ways of doing this. For a male already in puberty, let's say they're kind of in the early stages and they stopped for whatever the reason, they may be started on a slightly higher dose, 80 to 100 milligrams IM once a month for 6 months, then 120 to 140 for the next 6, 160 to 180 for the next 6. And then ultimately get them to 200 mgs IM every 2 weeks, about 1.5 to 2 years after you start the medicine. So again, very different ways of doing this, but all in all, you want to get them to the 200 mgs IM every 2 weeks. The goals of treatment are to get that slow, sustained, appropriate transition into puberty with an acceptable height velocity progression, avoidance of the closure of those growth plates I mentioned before, and achievement of secondary sexual characteristics for the individual themselves. They're usually the ones who are saying, when am I going to get more facial hair? When am I going to get more armpit hair? When is my voice going to change? When am I going to become more muscular? So their desires and what they want to see out of treatment are equally important. Some of the side effects that I wanted to just point out here from intramuscular testosterone, whether it be monthly or every 2 weeks, injection pain, usually with the first couple shots, is classically one of the biggest complaints we see, but eventually the pain is something that is no longer noticed. You can see here on the first illustration on the left, the difference between an intramuscular needle that has to go through several skin layers down to the muscle. It's injected at a perpendicular angle versus a subcutaneous needle, which is smaller, typically seen in growth hormone injections. It's given at an oblique angle and just through the first couple layers of skin to the fat tissue. Skin blistering is another thing we might see. And just for the sake of inclusion, on the right, there's an illustration of where the injection is typically given, typically the upper outer quadrant of one of the buttocks. So some things you may see and be able to monitor for at home, or more acne and mood swings. We apologize for that in advance. There can be increased blood pressure, increased hemoglobin and hematocrit levels, variable swings in testosterone, which I'll talk more about in a moment. They can develop gynecomastia, which is temporary, a nipple and chest enlargement phenomena. And there can be a temporary and non-permanent decrease in sperm production that does come back, and I will talk more about this in just a moment. So they do need pretty close follow-up with us to monitor their height growth curve and also monitor for those secondary sexual characteristic developments. We'll do testosterone levels, which we request usually a few days after an injection or a few days before an injection. These are known as the peak and the troughs. Some physicians will do both of these things. We'll also typically obtain once to twice yearly hemoglobin and hematocrit levels to ensure those are not rising too quickly or too high. And some physicians will send the individuals for bone age x-rays of the left hand every 9 to 18 months to ensure that the growth plates are not advancing too rapidly and that they're not closing prematurely. For the sake of inclusion, again, I just wanted to put down here at the bottom, prostate-specific antigen. Individuals on testosterone replacement can get slightly higher levels, and adult providers who are taking care of individuals on testosterone will be monitoring these as well, but this is not something we typically need to do for our pediatric patients. So are there alternatives to intramuscular testosterone? Well, in the pediatric and teenage group, yes, there are. Topical testosterone gel is the other option. And this is offered typically to males once they're on finalized intramuscular testosterone doses. It's typically given as 2 to 3 pumps applied once daily to the upper shoulder, chest side or back side, usually morning or nighttime when they're coming out of the shower. Most adult studies are the ones that have been done, and the ones that have been done have shown much higher patient satisfaction, as you can imagine, and more stable testosterone levels on a daily basis. The side effect, I would say, most importantly, is that this has got to be kept locked up. It can be very potent and have quite a side effect profile if women or children are exposed, particularly the young boy exposed. They can go into earlier what we call precocious puberty, and their growth can ultimately become quite accelerated and quite stunted long-term if they're exposed unexpectedly. Other alternatives to intramuscular testosterone that unfortunately have not been shown to be superior or even that efficacious in individuals, testosterone patch, seen here on the right, nasal and buccal mucosa forms. There's implantable pellets that have been used by some practices, but these are every 3 to 6 month surgical insertions. They can be painful. And there have been testosterone pills, but there's a much higher liver side effect profile. And longer lasting injectable intramuscular testosterone formulations have been studied, but there's a greater risk of pulmonary oil microembolization. Just a quick word on subcutaneous testosterone. As I showed you in a few slides, this is delivered via a smaller syringe and needle into the subcutaneous fat tissue right underneath the epidermis and dermis, and it can be given by an individual or a caregiver at home. There are drawbacks though. It's typically given once per week. Unfortunately, there's really been no prior studies performed in children. There's variable absorption, and we just don't really understand it as well in teenagers compared to adults, that it has been studied a little bit more. In the studies that have been done in adults, there's been shown to be higher risk of higher testosterone levels unexpectedly or lower testosterone levels unexpectedly. And last but not least, in both adults and children, teens, it's not FDA approved. So I think there's be more to come on this in the year or decade to come, but for right now, it's not something we typically prescribe for teenagers. So transitioning and jumping here to fertility, what can be done for these individuals? Is this something we need to be concerned about? So going back to this slide here, as I mentioned earlier, depending on where the individual had their initial lesion or tumor, whether it be the hypothalamus or the anterior pituitary, wherever it is, they don't make LH and FSH, they don't make testosterone from their testicles, and they have hypogonadotropic hypogonadism. And so without LH and FSH, this is sort of where we go into how fertility is affected. The hypothalamic hormone, the GnRH, stimulates LH and FSH here from the anterior pituitary. And it's this LH that stimulates testosterone production and release from a group of cells in the testicles called the Leydig cells. LH and FSH together are stimulated and secreted in utero, typically the third trimester, throughout early infancy, and then again later on during the prepubertal and adult years. The FSH stimulates Sertoli cell and germ cell formation within the testicles, and ultimately sperm production later on during the pubertal years and adult years. And it's this FSH stimulation of germ cells in the testicles that ultimately boosts the testicular volume and size throughout puberty, more so than testosterone production itself within the testicles from the Leydig cells. So again, GnRH, FSH, it's a phenomena in utero, early infancy, and puberty onward. There's this thing I wanted to talk about right now called priming of the sperm cells in the fetal and neonatal period. The hypothalamic-pituitary gonadal axis in males is activated sometime during the third trimester, and it remains active throughout the first 6 months of life. Hormonal changes include immature Sertoli cell and early germ cell proliferation. With this in turn generates a threefold testicular volume increase, and there's no true sperm production going on here. The phenomena that occurs through the 6 months of life then goes dormant until early puberty begins. And it's really this mini puberty seen during this 9-month period that likely has profound effects on future fertility, the likes of which we're not fully aware of yet, but we do know that Sertoli cell supports a finite number of germ cells, and that achieving a full complement of these cells is critical for spermatogenic capacity and fertility. So going back to this slide, I think this is one of the hardest points of the male fertility physiology to grasp. The testosterone that's made within the testicles plays a huge role in sperm productions, in that the testosterone really provides an adequate environment for sperm development. And so will testosterone treatments for the child with hypogonadotropic hypogonadism imitate this process and promote their own future fertility? Well, the short answer is no, because the testosterone you give to any individual, hypogonadotropic hypogonadism or not, sort of is delivered in their muscles and their bloodstream, and it goes back to the pituitary gland and it shuts off this whole process. And if FSH and LH are shut off, there's really no sperm production in the teenager or adult. And this is in any individual. In the hypogonadotropic hypogonadism population, we know that prior brain surgeries, whether it be at the hypothalamus or the pituitary, leads to a shutdown in these GnRH, FSH, and LH hormones. And therefore, you're not going to get that testosterone production within the testicles. You're not going to get intratesticular sort of maintenance of the sperm production. So are there fertility preservation options or treatments? And the answer is absolutely yes, there are. So what do we take into account as the adult fertility specialists? Well, the level of the lesion is noted, as this will play a role in the child's ultimately ability to conceive naturally without fertility treatments. Also, number two, those diagnosed with secondary hypogonadism after puberty typically show better responses to fertility treatments later on. Number three, the degree of hypogonadism is also a factor in these boys, as men with testicles judged to be not as small, as well as those with normal to low normal levels of FSH and testosterone typically show better responses. Number four, men with a history of undecided testicles beyond the first year of life typically show poor responses to treatment. So that's something to take into consideration. And something that these individuals might be asked by their adult fertility specialist is whether or not they've been on any prior intramuscular topical testosterone treatments. Although there have been some studies that have reported previous testosterone treatments have an adverse effect on the sperm cells long-term and those sperm cell responses to subsequent fertility treatments, recent larger review studies have not confirmed this. And so an individual can be on testosterone, whether it be intramuscular and topical at appropriate doses, and be able to get pregnant later on. So the biggest fertility preservation option that is available to these individuals, depending if they're at the right age, males in puberty or those who have completed puberty is sperm banking. And again, they have to be the right age and developmentally appropriate to provide the sample. It's available to those just about to undergo pituitary or hypothalamic surgery, and to those individuals or families who are interested. It's not always offered, but you can request it. And doctors, nurses, and social workers can kind of guide you to the right sperm banking facility in the local area. The initial freeze of the sperm cryopreservation is about $300. Yearly cost to maintain is $200 to $300, but unfortunately, insurance does not always cover the cost of the freeze or the yearly maintenance. So is it necessary to consider fertility treatments, to consider sperm cryopreservation? Well, it's not always necessary in those in puberty or beyond who have just been diagnosed with a brain lesion or tumor. There's a slightly higher rate of natural conception and pregnancy with a partner later on in life if that CNS tumor of the brain or lesion was diagnosed and removed during or after puberty. But if needed, there are options with adults fertility specialists, whether it be such modalities as intrauterine insemination, intracytoplasmic sperm injection, or in vitro fertilization. But again, these are not always needed. What about those diagnosed during childhood or infancy? Well, it all goes back to that priming I had mentioned earlier between that follicle stimulating hormone released from the anterior pituitary in utero in early infancy, those 9 months from the 3rd trimester through 6 months, and the preparatory action the FSH on the sperm cells and the testicles might play on germ cell function and sperm production down the road. Starting with the more straightforward group here that I've talked about on the left, men with hypogonadotropic hypogonadism of postpubertal onset can typically experience sufficient enough spermatogenesis either on their own or with a single fertility treatment agent. Children who develop hypogonadotropic hypogonadism from pituitary hypothalamic lesions sometime prior to puberty will certainly need a single agent fertility treatment and often will require a second one. More to come on this in a moment. And although the brain hypothalamus-pituitary tumor population among infants is relatively rare, it can happen, and they're almost certainly going to need 2 fertility treatment agents to produce a viable sperm, simply going back to that priming that occurs during the 3rd trimester through the 6th month of life. So what are these treatments? So just a quick mention here, when an adult male is undergoing infertility treatment evaluations and are given the options, it's typically recommended that they stop their intramuscular testosterone or topical testosterone 3 to 6 months prior to starting treatments. Again, they take testosterone and it kind of shuts down their body's own natural testicular function to make sperm. So they have to come off of it before they begin one of these. My apologies here. So the first one that I'm just gonna X this out so you all can see it is GnRH, gonadotropin releasing hormone. It's used in individuals who have no hypothalamus, but they have a functional anterior pituitary with FSH and LH. GnRH is given subcutaneously through a pump, but unfortunately it's only offered in Europe and it's quite costly, $7,000 per year. It's only been studied in adults and again, just European studies. The next option is human chorionic gonadotropin. It's a luteinizing hormone equivalent and it can be used for either hypothalamic or pituitary tumor survivors. It's given as an intramuscular injection 3 days of the week, and it's for the most part more affordable, about $120 to $200 monthly. There's a combination of follicle stimulating hormone and HCG therapies. That's an option for lesions at either levels, hypothalamus or pituitary. And it's typically used in adult males when HCG by itself alone has failed. FSH is by far the most costly of these 3 agents here, around $9,000 to $18,000 per year. And it's not always covered by insurances in all states. In our male CNS tumor survivor population, though, these therapies are rarely employed to help kickstart puberty due to, as you can see, how expensive they are and due to insurance approval difficulties. So just a quick mention here, talk to your adolescent, of course, about all of these things. Find out where they're at and explain to them what testosterone is going to do for their body. If all your child or teenager is looking to have that facial hair, armpit hair, musculature development, testosterone therapy is going to get them there, and it's going to get them there safely and effectively, and they're going to be satisfied with the results. It's usually the best, easiest, most affordable, and insurance-approved option, and fertility is still likely a viable option later on in life. So today, I hope you learned that the pituitary does play a vital role in testicular development and testosterone release. Intramuscular testosterone is widely used and studied in pubertal induction for hypogonadal males. Close collaboration with a pediatric endocrinologist is needed to ensure the most appropriate progression through puberty from not only a height perspective, but the development of those secondary sexual characteristics. Greater emphasis lately has been placed on alternative forms of testosterone, but few studies have really focused on children and teens. And last but not least, fertility outlooks and treatments in this population are complex and multifaceted, but they certainly are promising. So without further ado, I'll lend this to more questions. Thank you, everybody.